Enjoy your meeting.
Recording, and then I'm going to pass off control to you. Oh, actually, I'm sorry. I'm not going to
Just a
pass off control
reminder,
to you.
today's meeting is being recorded.
I'll pass it off to you on your title slide. Is that okay?
Okay. Yeah.
Excellent. Okay. So I see that we have Ian, I know Laura Sturgill, Larry's on the call. Lisa, are you on the call?
Yes, I had some audio, but now I'm good.
Great. Amy, I see you joined. Are you on? Maybe not audio. Sam Martin, can you hear me?
Yes, I'm here.
Okay, you're here. Great. And then Tabitha, can you hear me? Maybe not. Okay. Is there anybody else on the line that I didn't necessarily say yet?
I think there was an audio.
Hi, Ariel.
Hi.
Usually it just calls you, and for some reason that function wasn't working today, so I had to, it didn't audio call. Maybe those other people are waiting for the system to call them. I did it today.
Mine did when I did it. Yeah.
Hey, Ian.
Hi. How are you doing, Lisa?
How's life in the Northwest? I'm kind of jealous.
Yeah, it's pretty awesome, I have to say. We're renting this house that's overlooking Lake Washington, and every morning I look out and just feel really kind of surprised. It feels like it's probably going to be a few years till I get over feeling like I'm on extended vacation.
Wow, that's beautiful. That's great.
You guys have the Three Rivers to look out at, though.
We do.
Jessica, how do you like this iMeet versus some of the other systems that you can use?
So as a network, we haven't really tried many other software except for iMeet, and I know Larry's on the call. He might be able to talk about this from the FMEC perspective, but iMeet seems to be, once it's downloaded, really easy to use. It's pretty intuitive, and you have the capability of using it just audio or the audio and visual for like a webinar for today. And so I really like having both of those features because we use the audio call line a lot, even if we're not using slides.
Right.
So it's been working pretty well.
Well, the other point, Ian, about the iMeet is it's $50 a month, which is a pretty reasonable compared to. I looked at the other products that are out there, and this one's pretty reasonable, and it looks to me like it has all the features that that we would be using. So.
We had always used Adobe Connect, and I think we just paid for a year subscription for $250, which has unlimited, people to get onto it. But I'm not sure whether I haven't compared it in terms of the features and reliability and stuff to other systems.
Hello.
Sukanya?
Yes, hi.
Hey, how are you?
Okay.
Good. We're just waiting for people. Okay, great.
Hey,
We're just waiting for people
Sukanya,
to
it's Ian here.
Hi, Ian. How are you?
Great. How are you doing?
Okay, thanks. What were you saying, Jess? I'm sorry, I didn't hear you. You're waiting for?
Oh, we're just waiting for people to jump on. We were talking about different software for webinars.
Okay.
So just for time's sake, I know that Ian has a lot of great slides to go through, so does Steve. We also have some data slides. I'm going to get started with the webinar, and if you didn't already know, it is recording today, so I'll be able to send a link to this out to everyone in the network afterwards, which will be really nice. So today's focus is going to be on maternal depression, and we have Dr. Ratcliffe and Dr. Bennett presenting this morning. Before we kind of get into that, I wanted to welcome two very new people to the network. So one of them is Jessica Garber, and the other is Tabitha Reefer, and both of them are going to be funded by the Pennsylvania Department of Health grant that we were able to secure. And Jessica will be working at LGH, and she's going to serve as the Pennsylvania Network Coordinator. So it'll be very similar to my job in the sense of project coordination and CQI at LGH, whereas I would do UPMC, but then also network support. So she'll be able to support all of the sites, specifically out in eastern Pennsylvania, but as needed, her work will likely support the entire network. And then we also have recently been able to hire Tabitha, and Tabitha is going to be based here at UPMC, and she's going to be your practice facilitator. So she's going to work to develop case management strategies at UPMC, as well as work on network dissemination, specifically in western Pennsylvania, but likely collaborating with Jessica to also disseminate to new sites in eastern Pennsylvania. And both of these people are going to be crucial to help us meet our Department of Health grant outcomes. Lisa, did you have anything you wanted to say about either one of our new hires regarding their roles for the network?
I think you did a beautiful job in summary, just so that everybody on the call knows, even though we are, technically need to spend the funds in Pennsylvania, it will obviously extrapolate to programs outside of Pennsylvania because the good work we do, we obviously share all the time. But we are very excited to bring on these two new, very awesome folks to bring us to another level, and mostly to be able to utilize the data that we're all entering and hopefully get more programs up to enter data. So we're really excited, and the next couple of months is just going to be terrific.
Mm-hmm. So Jessica starts on,
you guys.
So Jessica starts on March 7th. She's actually at training right now for LGH, so she's unable to join. And I think that Tabitha is on the call, so I wasn't really sure what their schedules would be ahead of time. So I asked them both to send me brief bios. I just wanted everyone to learn a little bit more about them. But Jessica is in her final semester of her Master's of Public Health program at Penn State Hershey, and there she works as a research assistant intern for Nurse Family Partnership with LGH. And she monitors and compiles data for a program for women with postpartum depression. So that's really exciting because it'll help her transition a little bit easily into her ICC role. And she also coordinates and works as a research assistant for a PATH network at Penn State Hershey. And I don't know what PATH is an acronym for, but she helps with participants. She helps co-write research articles and helps to coordinate the different sites that are part of the PATH network. So that's a really nice skill set that she'll be able to adapt to IMPLICIT. And she spends her free time enjoying baking, running, and spending time with family and friends. And Tabitha is our new research assistant at UPMC. She recently graduated with her Master's in Public Health from the University of Pittsburgh, and she also has her Master's in Business Administration. She sits on a steering committee for Healthy Armstrong in Ford City as a volunteer and a consultant to the program. She also volunteers with Orphans of the Storm Animal Shelter and Armstrong Rails to Trail Association Katanning. And she also works as a consultant for the Pennsylvania Department of Health Bureau of Epidemiology. So both of them have lots of great experience that will be really applicable to their new roles, and we're really, really excited to have them to support our initiatives and our outcomes with this new grant. So then kind of going back to our objectives today, we're going to review evidence on maternal depression and depression screening. We'll present some implicit ICC data, and we also want to facilitate discussion and share best practice strategies for different sites throughout the network. So I'm about to pass.
I just want to see, is Tabitha you on the call?
Yes, I am.
Okay, great. I just wanted to make sure. I didn't know if you could hear if you worked out your audio. Welcome.
Thank you.
Excellent. So just to review, our webinar is really going to focus on the depression portion of interconception care today. So the Implicit Network has a model of interconception care that screens moms for 4 risk factors that affect future birth outcomes at well child visits for babies up to 2 years old. So while we as a network focus on smoking, depression, family planning, and multivitamin with folic acid use during these well-child visits. Today's audio call is really going to focus on the depression component of that. So with that, I am going to pass control over to Ian so that he can begin sharing some of the evidence regarding depression.
Okay. Hi, everyone. It's Ian here. I just was taking myself off mute. And it looks like I'm not sure that I have control. How do you advance, Jess?
At the bottom, do you see the previous and next?
Oh, yeah. Great.
Excellent.
Okay. Great. So actually, let me start by just saying hi to everybody, and also saying hi from the West Coast. For anyone who hasn't heard, I've actually moved to University of Washington out in Seattle, and I'm a professor there in 2 departments now. I had been in family medicine at University of Pennsylvania, and I'm in both the departments of family medicine and the Department of Psychiatry and Behavioral Sciences, which is a very nice bridge for me, and my work is continuing in the same basic area I was working before, but with a much stronger direct connection to psychiatry and the work that's being done out here on integrated mental health care, which is the stuff that you've heard me talking about sort of ad nauseum for a number of years. And just moving forward with that, the psychiatry department here at University of Washington just happens to be kind of an epicenter for working on how you bring evidence-based practices into a primary care setting to enhance outcomes. And there are a number of very high evidence-based models of care that will be influencing the presentation I'll be giving today that were really developed and evaluated here at the University of Washington. Not just in adult care, but also 2 very nice randomized trials showing the same benefits in perinatal care settings, whether OBGYN settings doing pregnancy and postpartum care, or primary care settings doing some perinatal care. So,
congratulations.
So we'll get started.
You know what,
I
Ian,
guess
actually,
if everybody could mute their lines just until they ask questions, that would be great. There's just some background noise coming through. Okay. So we're going to be, my presentation will begin with reviewing the same kind of topics we've talked about before, and for new folks it'll be new to you. But there will also be a section at the end where Steve Ratcliffe will review the new USPSTF data, or actually recommendations with regard to screening and treatment of depression in pregnancy and postpartum. So to start with the basics, we'll be going through different kinds of treatment options and thinking about how you approach a woman in pregnancy and postpartum. And, you know, of course, because we are focusing on ICC in this particular presentation, we'll spend most of our time talking about the postpartum and interconception period, so not when someone is actually pregnant. And that's because of the issues related to medication management, in particular in pregnancy, and that really deserves its own discussion separate from what we'll be talking about today. But there are, all of the non-intensive treatments are actually appropriate for use in pregnancy as well, and so we'll be talking about those things, and you can keep that in mind. We're going to be then talking about kind of matching diagnosis to treatment. What are the right kinds of treatments for folks with different levels of distress and actually diagnosable common mental disorders. And the common mental disorders of pregnancy and postpartum are the same as those for women who are not pregnant. That includes major depressive disorder and anxiety disorder, though dysthymia is an issue for some women as well. We will not be talking about other disorders which are much less common, such as bipolar disorder or other major serious psychiatric illnesses. So going on, and then we'll be talking a little bit about what the model is that we recommend through the IMPLICIT network. Just to remind everyone, it's a very common disorder, perinatal depression, and in general, we use the definition that is most commonly used for perinatal depression at this point, which is depression in pregnancy through the first year postpartum. Maternal depression is overlapping with this. It just is more, at this point, more commonly used the term perinatal depression. There is a high burden with it being the major source of disability for all adults at any age. It's the major cause of disabled years lost or disabled years lived, as evaluated by the Global Burdens of Disease folks that are now based here at University of Washington as well, that used to be at Harvard. It is associated with a number of disorders that are relevant to pregnancy and postpartum, including low birth weight and preterm birth. It's also associated with child mental health and disabilities, disorders of development that are shown both in high-income countries like the U.S. and European countries and low-income countries. There's a great benefit of treatment. We can see amelioration, risk modification by the effective treatment of depression in the mothers. So we know that, in fact, there's a strong evidence of causal relationship between depression and common mental disorders, but particularly depression and these disorders for children. The depression toolkit that we're really talking about, the set of things that we do that we recommend in the IMPLICIT network includes the evidence-based, highly efficient two-stage screening protocol in which we do a two-question screen initially, followed by one of the evidence-based more longer depression evaluation tools such as the PHQ-9 or the Edinburgh Postnatal Depression Scale. Either one of those is fine. Followed by the use of a diagnostic instrument by someone who's been trained to be able to use that instrument. The one that we've recommended for the use in the IMPLICIT network is the SCID. There are some other tools as well that can be used. And then the treatment tools, which include self-management contracts, symptom monitoring tools, and medication monitoring tools. This is just a quick summary of the different stages of treatment to remind people that there's the initial identification and evaluation component where we're screening, identifying the exact diagnosis that people have, initiating the appropriate treatment for that diagnosis. Then there's an acute phase in which initial treatments are carried out. People are followed up, and we're moved through a number of cycles sometimes to get the right treatment for people. So within 4 to 6 weeks, if people aren't improving, then moving to additional treatments, adding them to the approach that we had initially, or intensifying the treatment. That's called stepped care. And then when somebody is actually in remission, keeping them in remission as long as possible in the continuation phase is the way that it's generally described. And each one of these numbered points here is where we know there's a great variation in quality of care and a variation in what people actually do in the primary care setting or other mental health settings. So with regard to treatments and diagnoses, the minor depression or emotional distress, either these things which are sometimes referred to as subclinical depression, that represents quite a few women, especially in pregnancy and postpartum, where there's about the same number of women who can be diagnosed with a mental disorder, but there's a greater level of symptom distress for women in those particular moments. That's why you can get up to 50% of disadvantaged populations with screening positive for risk of depression. And that's the difference, of course, between risk of depression and high symptoms and actually a diagnosable disorder. If someone has minor depression or has symptoms that suggest to the clinician before they're actually gone through a diagnosis evaluation that they don't have major depression but they have emotional distress, then the level of treatment really should be limited to self-management contracts, increased physical activities, activation of personal support networks, getting people to go after those organizations or individual people that they find normally as a source of support, and making sure that they're really taking advantage of that. And a brief supportive counseling, the kind of thing that primary care providers do quite regularly, with telling people that they're doing a great job and keep up the good work, and the fact that they showed up here to begin with to get their treatment is really important. So that kind of supportive counseling is about the level of treatment that someone should get, as compared to someone who has major depressive disorder, dysthymia, anxiety disorders that are diagnosable, in which case you would need to, with regard to the actual guideline treatment, you would need to be thinking about antidepressant medications, intensive psychotherapeutic counseling, or the combination of those. Now, those would be layered on top of the treatments mentioned above. So everybody deserves these less intensive treatments, but then with someone who has a diagnosable disorder with severe symptoms, they would, by guideline treatment, deserve to get offered the antidepressant medications, intensive psychotherapeutic counseling, or the combination. And please, if somebody has questions along the way, feel free to speak up. So just to remind people, the DSM-4, actually I should have updated this, it's now DSM-5 criteria are the same as they were for DSM-4. We're talking about 5 or more of the major symptoms. There are 9 major symptoms overall that go into a diagnosis of major depression. They need to be present for 2 weeks straight in the last month, for most of the day, nearly every day, and it's a change from their previous functioning. So it doesn't need to be immediately before that last month, but there have been times in their lives when people have felt normal, quotes, and this is a change from that. The severity and significance of disability is an important part of diagnosing depression or anxiety. There's a marked severity afflicting life significantly, either in their domain of work or domain of general home life. These are just a quick reminder of the different CAPS domains or criteria for major depression, with the red ones identified here being required for a diagnosis of major depression, either depressed mood or marked diminished interest in usual activities. That's called anhedonia. But then you have these additional components of a diagnosis of depression, and these map onto the PHQ-9 tool, which we recommend that people use in the IMPLICIT network. Dysthymia, I'll just mention, does not necessarily require someone to have both of those initial criteria, the first 2 criteria, but they do have pretty severe symptoms, and it's necessary that they not have a previous diagnosis of major depression on their list, their problem list, because if that's the case, then they have the disorder of major depression, and they're just in a less severe stage of their symptoms overall. Minor depression is the same kind of deal, with just less severe symptoms, and they don't need to have any of the A criteria as mentioned before. The suicidal ideation is an important component, of course, to keep in mind when we have someone who's thinking about that life might not be worth living, or that they'd be better off dead. There are items in both the Edinburgh Postnatal Depression Scale and the PHQ-9 which address self-harm and thoughts of self-harm. It's necessary for us all, if we're screening for patients with mental disorders, and this is certainly a central part of primary care in general. So this is just a matter of bringing our approach that we would use in our general primary care patients to pregnancy and postpartum, making sure that we have a approach to evaluating the severity of the suicidal risk for these patients that are saying that they are having these thoughts. There are some really good brief approaches to doing a risk evaluation. We recommend the MacArthur Toolkit, page 15, and those materials are up on the website for the Implicit Network. They're available for free to anyone who wants to use them, and they have some very nice, rapid ways of asking some important questions and getting to the risk, the self-harm contract, where someone is able to promise that they will contact you if they start to think about hurting themselves. If the threat is significant, an evaluation for possible inpatient treatment needs to be offered to patients, and we have to have a way of being able to get them to a local psychiatric evaluation center that is generally associated with emergency rooms in hospitals. As far as getting people evaluated, it is really critical that we think about some other causes for people to have emotional distress and comorbidities that will complicate the treatment. That includes thyroid abnormalities. So for the first time you're evaluating with someone with high depression symptoms, sending a TSH and making sure that they're doing okay thyroid-wise. Screening for substance abuse, either alcohol or other substances. Thinking about bipolar disease, and there are, again, in the MacArthur Toolkit, some quick questions to ask about past evidence of mania, which would be the important thing to distinguish unipolar depression from bipolar disorder. And so then thinking about that, asking that question, and then a quick evaluation as usual for intimate partner violence, which can make people's symptoms much higher. This is a report that was published actually back in 2009, which was a joint report with ACOG and the American Psychiatric Association, reviewing the management of depression during pregnancy. Now, I know that's not the focus of this particular presentation, but it is important to remind everybody that this is really the document, despite some of the changes that people feel that they've heard since 2009. It remains the primary guiding document with regard to clinical treatment of depression in pregnancy and postpartum. There have not been policy changes or guidance changes since 2009 with regard to the approach to depression in pregnancy. Let's talk a little bit about that. It's important that there be a connection with psychiatrists for suicidality, psychosis, and bipolar disorder. With regard to preconception, the current major depressive episode, we want to recommend that people delay pregnancy until their symptoms are under control. And once the symptoms are under control, you can consider discontinuation. And of course, it's always a negotiation with patients what they're willing to do. But if people are stable, then it is possible to discontinue them through the first trimester at least, and then to consider restarting medications if people start to feel worse as they go through pregnancy. It is important, though, to always remember that continuing antidepressant medications through pregnancy is absolutely an appropriate option for patients who are interested in and desiring that, and who have history of major depression with really bad and high severity of symptoms, and for whom we know it's going to be quite hard for them to function through pregnancy without those medications. And of course, remember those other treatments that are less intensive but critical to have going whenever we're treating anyone with depression, actually. Okay. So as far as non-pharmacologic therapy goes, I mentioned to you these treatments before. This is now talking about these guidelines that were recommended for ACOG, by ACOG and APA. for mild to moderate depression, you can do it alone, as mentioned before, but adding it to intensive therapy is important. Self-management, increased physical activity, healthy lifestyle, and then adding psychotherapy, either individual or group counseling. The specific therapies which are evidence-based include cognitive behavioral therapies, which are generally brief therapies. We're talking about 6 to 10 sessions would be the evidence-based approach to these therapies. And as you develop relationships with psychotherapists, it's really critical for you to ask them, do they use a cognitive behavioral therapeutic approach? Because many folks, whether they're psychologists or clinical social workers, will not necessarily be trained in cognitive behavioral therapy or to necessarily think that it's the thing that they feel most comfortable with. And we really should be steering our patients to folks who are using the evidence-based strategies, CBT, cognitive therapy alone, or behavioral therapy alone, all of which are evidence-based for adult populations in general, and CBT within pregnancy and perinatal depression. Is it critical that we have a discussion of the risk and benefit ratio of treatment versus untreated depression? There is definitely a balance between those two. The risks associated, the potential risks associated with medication include a whole number of potential outcomes that have been associated with medication use. The problem is, of course, that we can't distinguish the risks associated with depression itself from those who are on medications during pregnancy, because they would have had depression to be on medications. So it's quite difficult to distinguish those two. And in fact, the risk, even with the evidence of harm, is quite low. Although there's an increase in risk, the overall risk remains quite low, on the order of 6 or so per 1,000 cases, which would have, for example, persistent pulmonary hypertension, which is about double the risk for kids who are not on antidepressants late in pregnancy. The SSRIs that are recommended include fluoxetine, sertraline, citalopram. Paroxetine is the one medication that we really should be avoiding, except in cases where women have been on paroxetine in the past, have severe depression, but only had benefit from paroxetine, in which case you could go ahead and use that medication, but again with the discussion of risk benefits with the patients. SNRIs like venlafaxine and other medications like bupropion have less evidence in pregnancy, and for that reason have been used more often by people, in part because there's less evidence of harm, or no evidence of harm actually at this point. Bupropion for smokers, that's the specific example where we should be recommending probably Wellbutrin to patients who are smoking in pregnancy, just because of the evidence of benefit for quitting smoking for those women. So contraindications to stopping medications include these folks here. Don't forget that ECT is safe in pregnancy, and for people who are really not doing well at all, or not caring for themselves, or at high risk for suicide, that ECT is something that should be considered. Don't forget that with regard to treatment guidelines, you've got an acute phase of 4 to 6 weeks, in which case you should have people to below 10 on the PHQ-9, so down in the mild range for their symptoms. We generally recommend people getting started on intensive treatments if they're over 10 and have evidence for actually being having one of these diagnoses of psychiatric disorder. If within 4 to 6 weeks they have not dropped below 10, they need to, or half the symptoms, that's the other way, that a clinical response would be cutting your symptoms in half from an initial treatment. And if they haven't done that within 4 to 6 weeks, we should be stepping up their care, either increasing the dose of the medication, increasing the intensity of the medication, or adding other treatments to their treatment, and then following up again in 4 to 6 weeks. A continuation phase lasts from 4 to 9 months. That's when we're really focusing on preventing relapse. And then the maintenance phase is at least 9 months following that continuation phase, where we're really focused on preventing recurrence. And that can be intensive monitoring or actually going in there and continuing the treatments that we have offered them and they use to get out of their acute phase. These are, I think we've really talked about these things already. In terms of choice of medications, just to remember that the fluoxetine and sertraline are probably the most common go-to medications for folks in pregnancy and postpartum. Don't forget that the initial doses, something like 50 milligrams of sertraline is a subtherapeutic dose. Do not leave people on 50 milligrams of sertraline. If you're going to expose them to that medication, get them to a therapeutic dose, which would be at least 100 to 150 milligrams before you would expect anyone to get better. If it's less than that, then you're just taking advantage of placebo. With regard to psychotherapeutic counseling, it's a little bit longer that you might leave them on to see if there's a response, something like 6 to 8 weeks. Don't forget to use these tools like the PHQ-9, particularly the PHQ-9, to actually measure their response. You that's part of their treatment, not just getting them started. In terms of the implicit care system, what we've recommended is a case-finding approach using screening and diagnosis with treatment protocols that follow these ACOG and APA recommendations. Clinical care support, using your phone, getting people, actually calling up patients periodically. If you have care managers in your practice, that is an evidence-based approach. We now have very good evidence that in multiple randomized trials, that having a team approach with a care manager that's connecting with their patients in between our visits results in much better improvement than usual care. We want to also have continuous quality improvement strategies where we're looking at the penetration, for example, of the patients that are eligible for our care, that are actually getting screened and treated if they're appropriate for that. This is just a conceptual model of the chronic care model that the team-based approaches have used. And the ideal sequence of care with the PHQ-9, PHQ-2 followed the PHQ-9 if they're positive for the PHQ-2 and only if they're positive for the PHQ-2, followed by a diagnosis phase, guideline-consistent treatment, and monitoring of symptoms. This is a basic conceptual model of the collaborative care approach, which is that evidence-based strategy, where you have a care manager who's working with the other folks, and you have a mental health specialist ideally reviewing cases with the care manager and the patient and the prenatal care or primary care provider. And here's some resources which we have all on our Implicit website for anyone who would like to look up more. Please feel free to get in touch with me if you'd like some more direct help with getting these models into place. And I'm sorry, I didn't update this email. It is, please, if anyone's interested, my email currently is iBennett@uw.edu, not this email, which unfortunately Penn has not turned off, so it continues to go into some kind of netherworld and not tell you that, in fact, I am not there anymore. And yeah, just the one thing is there's a dot between UW and EDU. Thanks very much, everybody.
Thank you. Great. Thanks, Ian. Does anybody have any questions for Ian before we move forward?
Hey, Ian, it's Lisa. I have a couple questions. I wonder if you could comment on, in your kind of review of the literature, since you live and breathe this stuff more than any of us, obviously there is the association between preterm birth and low birth weight, and we never would have chosen that as a risk factor. But I wondered if there was any evidence that treating the depression, now again, focusing on interconception care. I know most of your work is in pregnant women, but right now we're really focusing on the interconception piece for these women. Is there evidence that once the women, if we can get their PHQ-9, for example, less than 4, is there evidence that their birth outcomes improve with treatment? So we know the association is linked if they're currently depressed with the, poor birth outcomes, but is there evidence that if you treat them, then their outcomes are better?
Yeah, that's a great question, Lisa. There's only been one trial that I'm aware of the interconception strategy. That's a trial that I was involved with Jen Culhane a number of years ago. And we did have a depression treatment arm as part of that. It really addressed a whole bunch of different risk factors, not just depression. And those are women who had a previous preterm birth. The question was, can we reduce their risk of a subsequent preterm birth? And in that case, there was no evidence that it reduced the risk of a subsequent preterm birth. We were underpowered in that study, though, to really answer that question. So there is no evidence currently that for birth outcomes, there is a benefit to the interconception strategy. There is a conceptual underlying kind of argument that it may help, but we do have very strong evidence that for child growth and development, mainly development in the U.S., growth in countries like South Asian countries where calories are less common, that treatment of depression of the mom results in improvements for developmental outcomes for the children.
Great, thank you. And one other question about breastfeeding, since I know you, and thank you very much, that was a really nice review for a lot of us just to kind of get the updates. If you could just comment on breastfeeding and SSRIs. I mean, most of us do it all the time, but I want to know if there was anything new out there.
Yeah, there's a caution, and the same kind of risk discussion is worth having with your patients with regard to using medications in pregnancy. In the breastfeeding period. We know that all of the SSRIs are detectable and SNRIs are detectable in breast milk. So for anyone who's very concerned about that, it would be a reason to either stop the medication or not breastfeed. Those would be the two options. There is no evidence of any negative consequence for the child for being exposed to those medications. The worry is that there may be long-term effects that we have not been able to detect thus far.
This is Steve, and I've not looked at this for probably 2 years, but the issue with SSRIs and breastfeeding had to do with the long-acting ones, particularly fluoxetine, and with a relative recommendation for someone needing antidepressant therapy to use some of the shorter-acting ones like sertraline.
That's a great point, Steve. Sorry for that. Sertraline is detectable. It's just that if someone is breastfeeding, there just isn't very good evidence, but folks have recommended that since if you have the choice, then you go to sertraline. Now, all of these are balanced with what people are already on and have had benefit for. So those recommendations are basically for people who are not on a treatment already. So if you need to start something, then go to sertraline. Or if they haven't had evidence that they really only benefit from some medication like fluoxetine, in which case starting them, there would be a rationale for starting them back on fluoxetine if they've had a benefit from that.
Ian?
Any other questions from anybody? I think we'll go on to Steve's presentation if there aren't any other questions.
Ian, it's Sakanya. Can I ask a question?
Of course.
Okay. I'm just clinically trying to figure out how to help the residents and just folks once in a while we get through the health centers that have a history of bipolar and then come into the pregnancy care and the PHQ-2s and so on aren't really tailored to that. I just didn't know if there was some other tool you recommend. I know you said that, look, in the very beginning, one of your slides, you said this doesn't apply to bipolar, but I just wondered, because these people come in with these diagnoses, and we're always trying to make sure, to do the right kind of follow-up, because they may or may not have been on medicine, but they carry this history.
Yeah, that's a great question, Sukanya. So there are a couple things to keep in mind. One of the most important ones is that if they are coming from a vulnerable population and they're young, if they've been involved with the criminal justice system in any way as children, then they are at much higher risk of having been given the diagnosis of bipolar disorder falsely. This is not exactly. It's not exactly clear why that's the case, but one hunch is that the medications used for bipolar disorder are also a kind of chemical restraint, which is used by the criminal justice system to help people kind of calm down. And in order to give those medications, they have to give the diagnosis as well. So it's really critical that we take with a grain of salt these diagnoses for those vulnerable population, younger people. If they have been under the care of a psychiatrist in the past or a community mental health system and have been on these antipsychotic medications or mood-stabilizing medications, then that is more, evidence, and in fact that is a real diagnosis. And for those people, it's absolutely critical that we do everything possible to get them under the care of a psychiatrist as part of our management in pregnancy and in the interconception period. So, doing everything possible for this, including in the interconception period, going ahead and starting a dose of a mood stabilizer that they've been on in the past, I think would be the thing that we should really work for. Monitoring for mania is really critical. You do not want to start an antidepressant on like an SSRI without a mood stabilizer on board for someone who has what feels like a true diagnosis of bipolar disorder.
Okay. So that's maybe watching out for the diagnosis if it's real, or really getting them much sooner to psych or behavioral health than sort of just screening ourselves repeatedly with that incomplete maybe instrument. Okay.
Yeah, I mean the PHQ-9 is perfectly fine to use for someone who's having depression symptoms. It does not look for manic symptoms. For someone who's depressed, the PHQ-9 is the right tool for someone who has bipolar disorder in the depression phase. The issue is, starting treatments with medications would be inappropriate for someone who has bipolar disorder and without having a mood stabilizer on at the right dose on board first.
Okay, thank you.
And that's specifically because there's evidence that you can push people into mania with an antidepressant.
Okay, Ian, thank you for taking the time to answer some of those follow-up questions. And if anybody has any additional questions, Ian's really accessible via email. So with that, Steve, do you want to start with the USPSTF recommendation?
Sure. First off, Ian has been our evidence champion with perinatal depression for a decade, and we're delighted that he continues to play that role at University of Washington. We like to look for sentinel publications that they have impact on what we're doing with IMPLICIT. And once it was clear that Ian and I were going to team up with this webinar, the publishing of the USPSTF recommendations in JAMA in January were very timely. And what I'd like to do is just to summarize some of the highlights and the questions they attempted to answer with a very comprehensive review of the literature. So this is the citation The summary is essentially they've given screening for perinatal depression, both in pregnancy and postpartum, a level B recommendation that screening for depression should be done for women in this phase of their life. It should be implemented with adequate systems in place to assure accurate diagnosis, effective treatment, and appropriate follow-up, all of which were what Ian had detailed were in the designs of what we've been doing both with our prenatal focus IMPLICIT 1 and now for the last several years with IMPLICIT ICC. So they looked at 5 key questions, and the first one was, does depression screening, do these programs in pregnant postpartum women result in improved outcomes? And again, they're looking at hundreds of studies. They graded them by good, fair, poor, in terms of the study design, but essentially, looking at the world literature, probably 90% of these studies, if not more, use the Edinburgh. And the Edinburgh Postpartum Depression Scale was a tool that we used for about 6 years until we determined that the screening using the PHQ-2, we were having very, very few false negatives, that there was a high negative predictive value, and so we stopped using the Edinburgh, but it is still the dominant screening in the literature. But using the Edinburgh, they saw reductions of 18 to 59% in risk of depression at follow-up compared to usual care. This ranged from follow-up of 1.5 months to 15 months. They then saw a drop-off of effectiveness at 16 or greater months, but when you're looking at the time frame that we're looking at, which is roughly 1 to 2 years, they demonstrated effectiveness in decreasing the risk of depression by using a mode of screening with then some type of follow-up intervention/treatment. As Ian had talked about before, when they looked at 3 studies that were using the PHQ-9, 45% of the intervention patients reported a 5-point or greater drop in the PHQ-9, which is what our benchmark is, versus 34% of those receiving usual care. Odds ratio of 1.74 with the confidence interval excluding unity. So in other words, it was effective. By the way, I put in some citations that appear to strongly support what our model is about. Now, Barbara Yon is a very well-known family physician at University of Michigan, and in a practice-based research network called the TRIPT Practices, this is where they demonstrated the final point in terms of the 45% decrease of the 5-point. So that would be one that we would probably want to add to our list of key articles. Key question 2, what's the test performance of the most commonly used depression screening instruments in pregnant postpartum care? Well, again, they had 23 studies using the Edinburgh with an N of 5398, and they demonstrated a sensitivity in the range of 67 to 95% and specificity of 88 to 99%. There were actually more than one. Well, since there are only 3 studies using the PHQ-9, and one of them used something called the PHQ-8, it seemed the one that was most like our methodology was this article by Smith et al. and also Dwinda Jerdigan. Dwinda Jerdigan is a family doc at University of Minnesota, and this is something that has been a part of our bibliography, looking at the validity the 2-question screen and the PHQ-9. And I've got the citation there. And then I think maybe the Smith study, but the sensitivity specificities with the PHQ-9 are in the same range as Edinburgh. Edinburgh looks like it may perform somewhat better, but important to note that in this key article that they certainly gave credence and room to using the PHQ-9, which does appear to occur primarily in the U.S. compared to globally with the Edinburgh. Key question 3, what are the harms associated with primary care depression screening programs in pregnant and postpartum women? And interestingly, of all the trials they looked at, only one of them reported no adverse effects, and the other 5 did not report on harms. And this is the one that reported on the harms was the Wing et al. Study at the bottom of the slide. Key question 4: does treatment result in improved health outcomes? I think very much what Lisa was referring to, i.e., decreased depression, suicide attempts, ideation, and improved functioning. Well, 10 trials using CBT, cognitive behavioral therapy, all showed remission with treatment in the short term. All trials showed greater symptom reduction in the intervention. Boy, this is very confusing. I apologize, second point. It does not make sense the way that it's worded there, so we're just going to skip it. Interestingly, in this paper that again looked at hundreds and hundreds of trials, they only had one that was an RCT that used fluoxetine, and it showed a 10-point reduction in the Edinburgh scale after 12 weeks compared to a 7-point reduction in the placebo. And that's the Appleby citation at the bottom of the page. Key question number 5, what are the harms of treatment in pregnant and postpartum women screened positive for depression? This is where the folks who wrote this article seem to me to probably don't do prenatal and interpartum care, and they seem to be very scared by a number of entities where there have been reported associations. And I've got them listed here right off the article, everything from preterm birth, neonatal respiratory distress, which would go along with preterm birth, miscarriage, PPH, persistent pulmonary hypertension. And they kind of made the comment that since CBT works so well, why would you even use medication in pregnancy? I think most of us live in a world where CBT is extremely unavailable, whereas use of meds are. And the purpose of our discussion today is not to look at antidepressant use in pregnancy, but this particular article seemed to discourage it. The one complication they did talk about, which we know about, is this kind of a neonatal abstinence syndrome type thing with some mild tachypnea. And here in exposed versus non-exposed fetuses, the rate was 13.9% to 7.8%. And I would say that any of us that are using these agents just need to notify everybody around us that the baby may need just a little bit more of observation. This rarely translates into something significant, but if people are prepared for it, it's usually not a big deal. So because time, I would suggest that the meat of this talk is really looking at the data, and perhaps at our meeting on April 8th, we could perhaps tease out and spend more time talking about this very important U.S. Preventive Services new recommendation.
Excellent. So it's 1 o'clock, and our webinar was through post-last one, but we've gotten through some of our depression evidence, and that's been really important and certainly useful. So I can begin to move into the data, but I know some of you are going to have to jump off. And I'm also fairly certain that in a couple minutes, IME might kick us off, as it's done the past couple times we've used it. But for right now, I just want to remind everybody a little bit more about the ICC model. So due to a lot of the things you heard today, and specifically this idea that symptoms occur in 20 to 40% of women during pregnancy or postpartum, and that depression is a peripartum reoccurrence rate of 40%, we're screening mothers up to